Hi, this is Harris Carmichael, and welcome to our last section of Hematology and Oncology, Pharmacology. This will be a large section, particularly as we discuss the anti-neoplastic drugs, but let's start by discussing a topic that we've partly covered earlier in the chapter, anticoagulation pharmacology. Before beginning this section, it may help to quickly review the coagulation cascade and platelet plug formation. Heparin is a mainstay of anticoagulation therapy that acts by potentiating antithrombin, just like endogenous heparin does. Antithrombin, as we spoke about in physiology, then acts to decrease several factors, including thrombin, factor Xa, as well as factors 9, 11, and 12, therefore blocking coagulation. Would you think heparin has a fast or slow onset of action? Well, heparin has a relatively quick onset of action and a short half-life, as it only potentiates a substance that already exists in the bloodstream and does not alter any. It is used in situations where you want immediate anticoagulation, such as pulmonary embolism, stroke, acute coronary syndrome, MI, DVT, and in pregnancy. Heparin is used instead of warfarin during pregnancy because heparin does not cross the placenta, whereas warfarin does. So what lab test is used to monitor heparin? PT or PTT? Well, thinking back on the coagulation cascade, antithrombin functions on many different factors, and although it works more on 10A and 2, it also inhibits 9, 11, and 12. Knowing this, would heparin act more on the intrinsic or extrinsic pathway? That would be the intrinsic pathway, and this means that you would follow PTT. The other way to recall this information would be with our mnemonic WEPT for warfarin. Knowing that warfarin works on the extrinsic pathway and is followed by the PT lab test, we can remember that heparin is the opposite and functions mainly on the intrinsic pathway and is monitored with PTT. For a quick review, PT and PTT are measures of how well the coagulation cascade is functioning. PTT for the intrinsic and PT for the extrinsic, while blank is the measure of platelet plug formation. That would be bleeding time. If you were to overdose on heparin, as seen with significantly increased bleeding or prolonged PTT, protamine sulfate should be administered as the antidote. Heparin toxicities include overbleeding, osteoporosis, and heparin-induced thrombocytopenia. Protamine sulfate is a positively charged molecule that binds negatively charged heparin. Of note, there are low molecular weight heparins, like enoxaparin, available. These act more specifically on factor 10A versus factor 2 than unfractionated heparin, which act equally on factors 2 and 10A. Also, low molecular weight heparins have better bioavailability and 2 to 4 times longer half-life than unfractionated heparin. Finally, low molecular weight heparins can be administered subcutaneously and do not require laboratory monitoring. So what could be the downside? Well, one drawback would be that unlike unfractionated heparins, anticoagulation by low molecular weight heparins is not easily reversible. In heparin-induced thrombocytopenia, the body perceives heparin bound to platelet factor 4, also called PF4. The body then develops an IgG antibody against this complex. These antibodies are then bound by Fc receptors on circulating platelets. Some of this new heparin PF4 antibody platelet complex is then removed and destroyed in the spleen, leading to thrombocytopenia. Other complexes remain in the bloodstream in an overactivated state and form thrombi. This thrombus formation will also contribute to thrombocytopenia in the patient. So basically, HIT causes a simultaneous thrombocytopenic and hypercoagulable state, which seems like a paradoxical situation. If you are given a patient that has recently been started on heparin and now has a decreasing platelet count, you should really give consideration to HIT. If you do have a patient that you've diagnosed with HIT, you must immediately stop heparin and begin a non-heparin derivative, quick-acting anticoagulant. If a patient has an adverse reaction to heparin, you may want to use a Hirudin derivative. These Hirudin derivatives are named as such because they are synthetic versions of Hirudin, which is a natural anticoagulant found in some leech salivas. Examples are Leparudin, Bivalirubin, and Argatroban. Hirudin derivatives are direct thrombin inhibitors and can be used as substitutes to heparin products. They inhibit thrombin, or factor 2, directly, but they do not have an effect on factor 10A. These medications should be used in treating patients with heparin-induced thrombocytopenia who should not receive any heparin products after the diagnosis, but still require anticoagulation for their primary thrombotic pathology. One other direct thrombin inhibitor is Dabigatran, or Dabigatran, which is considered one of the so-called new oral anticoagulants, or NOACs for short. As the NOAC moniker implies, Dabigatran is an oral agent, unlike any other direct thrombin inhibitor. This is important because it can be taken as an anticoagulant in the place of warfarin in the outpatient setting for stroke prevention in atrial fibrillation. Another important distinction of the NOACs from warfarin is that at this time they do not require periodic monitoring of coagulation markers, as warfarin does with INR. The remaining NOACs will be discussed in a later section because they are factor Xa inhibitors and not direct thrombin inhibitors. Warfarin, also known as Coumadin, interferes with the normal synthesis and gamma carboxylation of vitamin K-dependent clotting factors 2, 7, 9, 10, and proteins C and S. Warfarin is used for chronic anticoagulation and can be used in the home setting. It is classically used for venous thromboembolism prophylaxis. It is not used in pregnant women because warfarin can cross the placenta and acts as a teratogen. Warfarin is metabolized by the cytochrome P450 pathway, thus P450 inducers and inhibitors can affect the efficacy of warfarin. You may recall these inducers and inhibitors from Pharmacology, and be sure to review them if you do not, because they are very high yield for your test. So what lab do you follow to monitor the effects of warfarin? Well, remember that warfarin works on the entire extrinsic pathway, so check the PT, or related international normalized ratio, INR, to follow warfarin. To remember this, you can use the mnemonic, the ex-president went to war, Farin. You can also use the mnemonic WEPT, standing for warfarin, extrinsic, and PT. Warfarin toxicity can cause bleeding and skin or tissue necrosis. To reverse the effects of warfarin slowly, vitamin K can be given. What could you do if you wanted to reverse the effects of warfarin quickly? Well, you could simply replace the clotting factors that are deficient with fresh frozen plasma as necessary. The decision between the two is made based on how severe the situation is. If a person is acutely bleeding, you'll opt for fresh frozen plasma, but if you need to normalize the vitamin K for a scheduled surgery that's in a few days, you can give vitamin K. Now let's compare heparin and warfarin head-to-head. Heparin is a large anionic acidic polymer, and because of this, it cannot cross the placenta, whereas warfarin is small and lipid-soluble. Warfarin can easily cross the placenta and should not be given to pregnant women. What routes are available for heparin? Well, heparin can be given IV or subcutaneously, but this makes it very difficult to manage in the outpatient setting. Warfarin is administered orally, so patients can take it at home. Heparin works in the blood, while warfarin works in the liver. Heparin is much more useful in the acute setting because it has an onset of action within seconds. Warfarin is slow to take effect, so heparin is often needed in a, quote, heparin bridge to keep the patient anticoagulated until warfarin begins to take effect some 3 to 4 days later. Heparin has an antidote, protamine sulfate, whereas a warfarin overdose requires IV vitamin K or fresh frozen plasma. Lastly, heparin is best monitored with PTT for the intrinsic pathway, while warfarin is best monitored by PT or INR for the extrinsic pathway. Direct factor Xa inhibitors bind and directly inhibit Xa. These are the remaining two so-called new oral anticoagulants, or NOACs. They are apixaban and rivaroxaban, both conveniently ending in aban. And these are oral agents used in DVT in pulmonary embolism treatment and prophylaxis, and in stroke prevention in a patient with atrial fibrillation. Toxicity will cause bleeding, and unlike warfarin, there is currently no reversal agent for this toxicity. The upside, however, is that these agents do not require continuous coagulation monitoring, as warfarin does. Here's a quick flash quiz for us. If a patient was diagnosed with heparin-induced thrombocytopenia, what drug class would commonly be administered? Well, after immediately stopping heparin, the patient would commonly be started on a hirudin derivative, like Argatroban or Bivalirubin. Now we move on to the thrombolytics. Thrombolytics are useful soon after thrombotic events, like if someone has a PE, MI, or ischemic stroke. What would be your first line of therapy for an MI? Well, your first line of therapy would actually be percutaneous intervention, but a lot of times you cannot get a patient to a cath lab facility in time, so your next resort is to dissolve these clots using thrombolytics. And remember, you only have a short window of opportunity to use these drugs. They must be administered within minutes to hours of an inciting event. And as the name applies, these drugs break down thrombi. Examples include streptokinase, urokinase, alteplase or TPA, retiplase, and tenecteplase. Thrombolytics act directly or indirectly by converting plasminogen to plasmin, which goes on to cleave thrombin and fibrin clots. After use, the PT and PTT will increase because you're affecting the common pathway. But will bleeding time be affected? Actually, no. Bleeding time will be unchanged because platelets are not affected. The main danger with thrombolytics is lysing clots that the body actually needs. For example, a patient with recent surgery needs clots to keep from bleeding profusely. Other examples include active bleeding or a history of recent intracranial bleeding. In these patients, it is risky to give thrombolytics, and in many cases you cannot give thrombolytics after these events regardless of current thrombus. Toxicity of thrombolytics is managed with aminocupuric acid, which acts by inhibiting fibrinolysis. The next class of drugs we'll discuss are the antiplatelet agents. The most common in this class is, of course, aspirin. Aspirin acetylates and irreversibly inhibits the COX enzymes, both isoforms, to prevent the conversion of arachidonic acid to thromboxane A2. We know that thromboxane A2 is a prothrombotic agent, stimulating activation of new platelets and increasing platelet aggregation. Hence, aspirin is an antiplatelet drug that reduces the ability of platelets to form clots and increases the bleeding time. But would this action change the PT or PTT? No, aspirin has no effect on the PT or PTT, as it has no effect on the coagulation factors. Because aspirin's effects on platelets are irreversible, and because platelets are just fragments of cells with no ability to synthesize new COX enzymes, the effects of aspirin last until new platelets are synthesized, which takes 8 to 10 days. Toxicity includes gastric ulcerations, tinnitus, which is a ringing sound in the ears, and Reye's syndrome in children with a viral infection. Importantly, recall from your respiratory chapter that an overdose causes respiratory alkalosis and a metabolic acidosis. As a quick review, when platelets first adhere after binding GP1B and von Willebrand factor, they release calcium and ADP. ADP then binds the ADP receptors of other platelets, which cause the activation and expression of GP2B3A receptors. GP2B3A receptors are what bind fibrinogen, which eventually converts to fibrin and cross-links platelets in the forming clots. Some antiplatelet medications act by irreversibly blocking the ADP receptor. Drugs with this mechanism of action include clopidogrel, ticlopidine, prasugrel, and ticagrelor. What would blocking this ADP receptor do? Well, by blocking this ADP receptor, platelets are unable to activate and therefore unable to express the GP2B3A receptors. ADP receptor inhibitors are used in acute coronary syndrome, which includes ST elevation MI, non-ST elevation MI, and unstable angina, and is also used during coronary stenting. They decrease the recurrence of thrombotic stroke as well. The most common side effect of these medications is bleeding, but ticlopidine in particular can also cause neutropenia, which can manifest as fevers and mouth ulcers. This is one reason why clopidogrel is preferred in the hospital setting. Next up on our antiplatelet drugs is Cilostazol and Dipyridamole. Interestingly, pulsatile cyclic AMP activates platelets, but constitutively high levels of cyclic AMP inhibits platelet aggregation. These two drugs are phosphodiesterase III inhibitors that maintain constant high levels of cAMP in platelets. Cilostazol and Dipyridamole can be used for prevention of stroke or transient ischemic attacks, usually in combination with aspirin. They are also used for peripheral artery disease that gives you intermittent claudication, as well as angina prophylaxis. Do you recall a different application for Dipyridamole? Dipyridamole is also what they use for cardiac stress tests. It causes cardiac vasodilation, which causes a coronary steal syndrome that appears on EKG as an abnormality. So let's talk about the GP2B3A inhibitors. Apixaban, eptifibatide, and tirofiban all bind the GP2B3A receptor on activated platelets, preventing the aggregation after activation. Apixaban in particular is a monoclonal antibody made from Fab fragments. These drugs are used in unstable angina and coronary angioplasty. Side effects include bleeding and thrombocytopenia. We've discussed this class previously in that its action is analogous to the pathology of what disease? That would be Glanzmann's thrombosenia. Remember that Glanzmann's thrombosenia is a defect in the GP2B3A receptor, and therefore GP2B3A receptor inhibitors would mimic that disease process. To review, ADP receptor inhibitors are used in what diseases? Important disease relationships for your exam with the ADP receptor inhibitor drug class are acute coronary syndrome and coronary stenting.